All right. So welcome to the first webinar of the McLean Hospital Crafting Support Project 2026 Family Webinar Series. I'm Dr. Julie McCarthy, and I'm a clinical psychologist and researcher at McLean Hospital. Tonight, I'm very excited to have you with us for a presentation on trauma and PTSD and serious mental illness, how families can help with Dr. Kim Mueser from Boston University. Before we begin, I'll go over a few reminders. So folks are welcome to change their name for privacy. If you want to ask questions or include any comments in the chat anonymously, please enter any questions that you would like answered in the Q&A box, and we'll be answering those at the end of the presentation. And we do ask that you use the polls for audience participation and also to share any information that you might like with us. And we will be recording this presentation, and when recordings are available, we'll let folks know. And to continue to improve the webinar series, we encourage you to complete a brief anonymous voluntary feedback survey to share your thoughts, preferences, and ideas for future webinars, because we want to make this as useful as possible for all of you. So this helps us for quality improvement, maybe shared anonymously in the future with other researchers or people who are interested in expanding supports like this for other families. So if you have to go early, I'm going to put this in the chat now, and I'll share it at the end as well. Okay, so first up, we'll be going over a little bit of a background for where this webinar series came from in case you're new, then we'll go into the presentation Q&A and closing remarks. All right. And one thing that we often like to do at the beginning of our webinars is to kind of get a little bit of a sense of who's with us tonight. So let me pull up our poll for tonight. Okay, so if you don't mind, please feel free to describe your role. Family member, person with lived experience with mental health challenges, clinician, or none of the above if we missed a category, and feel free to select more than one if you may have intersecting roles tonight. Okay, so we'll give folks another couple of seconds. Okay. And someone also shared in the chat, mother, caregiver. Yeah, thank you. All right, I'm going to close the poll in 3, 2, 1. Here we go. Okay, so I'm going to share the results now. Hopefully you can all see this. So it looks like almost 80% of folks with us are family members. We've got about 7% who are people with lived experience and about 25% who are clinicians. And then one person who may fill a different role. All important, and we are so happy to have everyone with us tonight. Okay, so part of the reason why we are all here is because either we probably have folks in our personal life or professional life where someone has a loved one, someone they care about who may be in need of help for one reason or another. And for many of us, we may have found ourselves at a time where we didn't exactly know what to do to help that person the best way possible. And so, since that time in my own life too, I've learned a lot about different skills that could be helpful for people with all types of different mental health experiences as they navigate recovery in whatever form makes the most sense for them. And this webinar series is really meant to bring together evidence-based approaches and resources that could help you or people who you know in your personal life or practice. So if anyone has other ideas for what you'd like to hear about, definitely let us know. What we have for this year, for 2026, is a great lineup of speakers, including Dr. Mueser tonight. So we've got information on stigma, about navigating psychosis care, thinking about navigating mental health resources for families, like with NAMI, the Cold Resource Center, Schizophrenia and Psychosis Action Alliance, and our programs at McLean. We also have the LEAP approach and anosognosia, thinking about how to help families coping with addiction, dealing with inpatient hospitalization, and a family recovery night where people with lived experience and their family members kind of share what's been helpful for them. And if you've missed some of our past webinars, feel free to check the recordings out on YouTube. There's a link in the QR code here if you're interested. And for folks who are looking for more one-on-one support, we do have a new Crafting Family Support program at McLean that's insurance-based, working with me or someone who works on my team. This is on Zoom typically, and this is ongoing from now for the foreseeable future. This is open only to Massachusetts families at this time. So if you're interested in learning more, feel free to get in touch at jmccarthy@mclean.harvard.edu. So our second poll before we get started with tonight's presentation is about how familiar are you with treatments for PTSD? This is absolutely not a requirement for joining us for the webinar tonight. It's more kind of getting a sense of where people are starting at in terms of their understanding with this topic. So you could say 0, not familiar at all. 1, mildly familiar. Maybe you've heard of a treatment, but you don't actually know what it is. 2, moderately familiar. Maybe you've done some reading about a treatment or two for PTSD. Or 3, very familiar. Maybe you've participated in treatments for PTSD or trauma, or even provided some treatments as well, because I know we have a number of clinicians on the call. All right. So we'll close the poll in 3, 2, 1. Okay. So it looks like we have quite a mix. So about 20% not familiar, 24% mildly familiar, 33% moderately familiar, and 15% who are on the very familiar side. So all across the board, it sounds like this would be a really helpful topic for everyone to learn more about. So with that, I'm going to turn things over to you, Dr. Mueser. And by way of introduction, if people are not familiar with Dr. Mueser, he's a clinical psychologist and professor at the Center for Psychiatric Rehabilitation at Boston University. His clinical and research interests include family psychoeducation, and there we go. And treatments for co-occurring psychiatric and substance use disorders, psychiatric rehabilitation for serious mental illnesses, including cognitive remediation, vocational rehabilitation, illness management and recovery approaches, and importantly, the treatment of post-traumatic stress disorder. His research has been supported by numerous grants from the National Institute of Mental Health, National Institute on Drug Abuse, the Substance Abuse and Mental Health Administration, and the Brain and Behavior Research Foundation. He's the co-author of over 20 books and treatment manuals, and that number is growing, and has published extensively, including over 400 peer-reviewed journal articles and book chapters. And I've been very fortunate to call Dr. Mueser one of my mentors. So thank you so much for being with us tonight. Feel free to take it away.
Thanks so much, Julie. I'm really delighted to see so many people at this presentation, and I'm just going to jump right into it because, as usual, I have too many slides. To begin, I'd like to define a traumatic event the way I'm going to be using it in this presentation, which is using the DSM-5 definition of an event involving some direct threat of death, severe bodily harm, or psychological injury to the self or another person. Now, when we talk about traumatic events, the most common traumatic events in the general population, and these are also very common in people with serious mental illness, are rape, sexual assault, combat, accidents, being a victim of crime or assault, natural disasters, and the sudden unexpected death of a loved one. But there are also some unique traumatic experiences that people who have had a psychotic episode may have had, and that can include psychotic symptoms that are terrifying. We'll talk a little bit more about this. Involuntary treatments, such as involuntary hospitalization, being in seclusion or restraints, and being threatened in an inpatient setting. For the most part, most of what I'm going to be talking about are the common traumatic events in the general population, but I will address events that are specific to developing a serious mental illness and some treatment for that. So let's just talk a little bit about the problem or the challenge of trauma in people with serious mental illness. There are very high rates of trauma in people with serious mental illness, and I'm using kind of a broad spectrum of serious mental illness, including a schizophrenia spectrum or psychotic disorders, bipolar disorder, major depression, borderline personality disorder, and the like. And we know that trauma increases the risk of people developing a serious mental illness. We know that people with serious mental illness often have experienced multiple traumas, some before they develop the illness and some after they develop the illness. And we also know that a history of trauma is associated with more severe symptoms, worse functioning, and greater use of acute care services. And we also know that service users, people with a serious mental illness, report traumatic experiences are important but frequently neglected in treatment. So a little bit about the trauma of psychosis, meaning the development of a psychotic episode. This could also include, for example, an episode of mania. These experiences can be traumatic for both the client and they can also be traumatic for relatives as well. PTSD reactions that can occur to both the psychotic symptoms themselves and treatment experiences, as indicated, like involuntary hospitalization. And we've done a bunch of research, as have others. And it turns out between about 31 and 46% of people with the first episode of psychosis have the PTSD syndrome, meaning they have the symptoms of PTSD consistent with the other types of traumatic events that we talked about. And we know that the people who have PTSD symptoms related to their psychotic symptoms or treatment experiences report higher levels of distress and worse functioning. So let's talk a little bit about what post-traumatic stress disorder is. And then after that, I'm going to talk a little bit about, well, why focus on PTSD in particular. So in order to be diagnosed with PTSD, according to the DSM-5, a person needs to be exposed to a traumatic event, as previously defined, and then they need to have at least some symptoms in each of the following four categories. Intrusion symptoms. The most common intrusion symptom is a memory of the traumatic event popping into somebody's head when they least expect it, sometimes when they're even trying to avoid it. Flashbacks are a little bit less common, but it's where somebody is momentarily transported back to the event as though it were happening again. Nightmares is another kind of intrusion symptom. Avoidance of trauma-related stimuli is the second group of symptoms, and that could be avoiding memories, situations, and things like that that remind the person of the traumatic event. The third cluster of symptoms is overarousal. Hypervigilance, people often seem like they are on constant guard. Difficulty sleeping because of this overarousal. Anger outbursts, having an exaggerated startle response. And then the last one, this was just added in the DSM-5. It wasn't in the previous definitions, although I have to say I'd never worked with somebody with a previous definition of PTSD who didn't also have this cluster of symptoms, and that is negative alterations in cognition and mood. People may be unable to remember parts of the event. They may have persistent negative feelings, detachment, free-floating feelings of anxiety, guilt, and so on. Now, there are many other symptoms that are frequently associated with PTSD, but are not involved in the definition of it or the diagnostic criteria. Suicidality is unfortunately very common, and effective treatment for PTSD actually reduces it significantly. Substance use disorders are common. For many people, it is a kind of an escape or temporary escape from traumatic memories and the like. Interestingly, we know that both hallucinations and delusions happen in people with PTSD, even when they can't be explained by another disorder like schizophrenia or bipolar disorder or major depression. And they tend to occur. Sometimes they're related to the trauma, sometimes they are not. But people with more severe PTSD are more likely to have those. It's common for people to have interpersonal difficulties because, unfortunately, much of trauma is, in fact, interpersonal, so it's harder to develop trust in other people. And there are difficulties in functioning, such as unemployment, work functioning, school, and the like. So why focus on PTSD as opposed to the broader range of traumatic events? Well, there's a number of different reasons. First of all, there's a high prevalence of PTSD in people with serious mental illness. A couple of large meta-analyses of PTSD and serious mental illness indicated that the rates were between 30 and 33% in two different studies done in 2013 and 18. Prevalence tends to be somewhat lower in people with the first episode of psychosis, probably in the 5 to 15% range. Another reason it's important to focus on PTSD is that it's often undetected in people with serious mental illness. And at the same time, PTSD is associated with very high levels of distress and increased rates of rehospitalization. The assessment of PTSD is quite straightforward, and psychological treatments for PTSD have been shown to be very effective, first in the general population for over 20 years, and now there's a whole bunch of studies showing that they're effective in people with serious mental illness. And last of all, we know that PTSD worsens the course of serious mental illness. So the reason to focus on PTSD rather than more broadly on trauma is that it's a specific disorder that we know a lot about. We know it's very common, and we actually know quite a bit about how to treat it. This picture just depicts a bunch of different studies looking at rates of PTSD in people with serious mental illness. You'll notice that the asterisked ones, there are three they're asterisked. And those are first episode psychosis studies where the rates are somewhat lower. And so what that probably means is that a bunch of trauma happens after people develop a serious mental illness, but of course, a significant amount happens before as well. So let's talk a little bit about the assessment of PTSD. Um, First of all, there's a lot of concerns that people sometimes have in terms of distinguishing between psychotic symptoms and hallucinations and delusions. And these are, generally speaking, fairly straightforward. You can have psychotic symptoms that, in fact, are PTSD symptoms, or they can be psychotic symptoms that are related to the serious mental illness. And if they're experienced as hallucinations and they're trauma related, they're frequently considered to be intrusion kinds of symptoms. I'm going to talk a little bit more about delusions, not because it's a challenge in the differential diagnosis, but often people are at least concerned about it. There's also the association between negative symptoms, distinguishing negative symptoms and withdrawal of symptoms. And the real difference is that the withdrawal or avoidance symptoms in PTSD are aimed at reducing anxiety because of the fear involved in trauma-related stimuli. Whereas negative symptoms have to do with a reduced drive to be with other people, to engage in pleasurable activities, and so on. And then manic or hypomanic symptoms. Again, the distinction is fairly straightforward. But let's talk a little bit about delusions. Do I have? Nope. Sorry. I'm just going to mention the thing about delusions. By and large, vast majority of research shows that reports of traumatic events in people with a serious mental illness, in fact, are valid reports. Concerns that delusions frequently result in reports of traumatic experiences, which used to be a concern, many years ago, really have not been held up. But it does sometimes happen that people have delusions about traumatic events that, in fact, did not occur. The basic idea in terms of trying to distinguish whether something occurred or not is to be aware that delusional-based traumatic reports usually are extreme cases of a trauma, often involving multiple perpetrators. They may involve things such as satanic worship and the like, which we don't really have any evidence actually exists. And it's very difficult to get any verification at all in terms of history and the like. And so the extreme reports of trauma that seem out of whack with a person's developmental history and reports of significant others are the ones that you might be concerned about in terms of not actually happening, and in which case we try not to treat them as post-traumatic events, but rather take a CBT approach in helping the person work on getting their lives back on track. Let me go into talking a little bit about assessment. Assessment of trauma and PTSD is really pretty straightforward. You can screen and identify a person with a high probability of having PTSD in about 15 minutes. And essentially what you do is there are two screening measures that are used, and these have been very well validated in people with a serious mental illness. I'd like to point out that there's no real typical person with serious mental illness who has PTSD. It's not necessarily an easy thing to pick up in many cases. And one of the reasons is that, of course, one of the symptoms of PTSD is avoidance of trauma-related stimuli. And so what that means is that a person with PTSD will typically not talk about their traumatic events. They won't tell you about things that happened. They won't tell you about intrusive memories and things because they're trying to avoid those trauma-related thoughts and feelings and the like. And so a person might have a significant trauma history and even have significant PTSD symptoms, but even a very seasoned a clinician might not be aware that they have PTSD if they didn't screen for it. And so that's why we actually recommend clinicians routinely screen for post-traumatic stress disorder. The screening, as I said, takes place in two steps. The first is a brief screen for traumatic events. And there's a number of screens available. We have one in our book. I'll show you a picture of it. That has about 18 items. And you simply inquire. It can be done as a self-report or as a semi-structured interview. And we simply inquire whether the person has experienced each of these events during their life at least once. And so one is combat, one is a sexual assault in childhood, and so on and so forth. Then, after you go through the different traumatic events, assuming the person has at least one, and most people do have one, even in the general population, most people have at least experienced one a traumatic event. You ask the person of all of these events, or could be a type of event, because certain events can happen again and again, like childhood abuse. You ask them which of these events is bothering you most now when you look back on it. You're not asking which was most distressing at the time, but rather which one is most troubling now. And that's because PTSD is a disorder of the presence. It's a disorder in which the past keeps revisiting the person in terms of intrusions and things like that, but it's of the present. And so the most important traumatic events to identify are those which are currently bothering the person. Then, when you've identified an event or maybe a group of events, what you do is you give out the second screening measure for PTSD, which is something called the PTSD checklist. And this has been widely used for over 30 years. It's a checklist in which you have the 21 symptoms of PTSD listed, and the person indicates how much they've experienced that symptom over the past month. There are different versions of it, 3 months, 1 week, kind of thing. But past month is what we usually use. And then you can sum up the responses on this PTSD screening measure, the PTSD checklist, and there are cutoffs, a 33 for the PCL-5, the PTSD checklist 5, is the cutoff for probable PTSD. And of course, it can be confirmed with clinical interview and things like that. But that's the basics of the assessment of trauma and PTSD in people with a serious mental illness. So now let's talk a little bit about treatments for PTSD in the serious mental illness population. And the treatments that I'm going to be talking about here all have at least some empirical support. I've written individual treatments for PTSD because all these treatments are individual. And in fact, in the general population, the best evidence for effective treatments for PTSD is in terms of individual treatments. There are benefits in terms of group-based treatments, but they're usually not primary treatments. They're usually more supportive interventions. And so the individual treatment is more common for PTSD, both in the general population and among people with serious mental illness. So the first program I'm going to describe is the cognitive restructuring program. And the term cognitive restructuring can be thought of as essentially synonymous with cognitive behavior therapy, where the focus of cognitive behavior therapy is on understanding the role that thoughts play in determining behaviors, as well as the fact that not all thoughts are equally accurate, and essentially teaching people how to monitor their thoughts, how to evaluate them, and how to change them when they're inaccurate. And there are cognitive models of PTSD in terms of how a traumatic experience influences people's thoughts and beliefs about themselves, about other people, whether they can be trusted and the like, and the world. And these thoughts can often be distorted by the traumatic experiences. And so the cognitive restructuring program, which is very similar to a program widely used in the VA called cognitive processing therapy, was specifically designed for people with serious mental illness. It is 12 to 16 sessions long. It begins with 3 sessions of psychoeducation about post-traumatic stress disorder. And that means explaining to people what it is as a disorder, the characteristic symptoms and things like that. It lets people know that they're not alone, and also lets them know that doctors or people in the medical field understand a lot about PTSD and how to treat it, which often makes people relieved because it gives them hope that there are effective treatments. And then we also teach a relaxed breathing exercise to help people reduce their anxiety. The primary focus of the program for most of the remaining sessions is on teaching clients how to identify, challenge, and correct inaccurate trauma-related thoughts underlying PTSD symptoms. Of course, in all CBT, what we do is we start with not necessarily trauma-related thoughts, but any upsetting thought. Could be feeling depressed, could be feeling anxious or guilty, And we teach people the rudiments of cognitive restructuring with these kind of everyday troubling negative feelings. And then as people get better and better at the skill, we move more towards trauma-related thoughts and cognitions that underlie the PTSD symptoms. So teaching cognitive restructuring enables traumatic experiences to be integrated into the person's understanding of themselves and the world. Probably all treatments for PTSD do this. They just take different approaches. Exposure therapy is another approach. And I want to say there's now 4 studies of cognitive restructuring for people with serious mental illness, controlled studies. There are at least 2 good controlled studies of exposure therapy and of eye movement desensitization and reprocessing as well in people with serious mental illness. So exposure therapy is about the same length. It usually begins with a similar number of sessions on psychoeducation and relaxation skills. But in exposure therapy sessions, what you focus on is prolonged imaginal exposure to upsetting trauma-related memories. And by this, what we mean is we have the person essentially close their eyes, identify what is the most upsetting memory, and then talk us through it. In other words, explain everything that happened in that memory from the beginning to the end. And then when they get to the end of it, we have them start all over and do it again and again and again. Now, it may sound rather mean, but actually it's very, very humane, because what happens is that the anxiety that people had the first time they went through it, and often the anxiety is the very worst, the very first time they go through it, that anxiety gradually goes down each time they tell it as they learn that the memory can't hurt them. They're reacting to the memory as though it's the real event, but it's not. It's a symbol of the real event. And that's what happens with the imaginal exposure. And they become able to tolerate it, even to the point where it doesn't raise the same level of anxiety and distress that it used to. And then what you also do is you identify feared but safe situations that the person may be avoiding because they remind the person of the traumatic event. It could be something as basic as not going into a store because of not wanting to go to a male clerk at a cash register. It could have to do with not driving or going to a particular parts of a city where one was assaulted. And what you do is you work out a plan for the person to expose themselves gradually to those situations, with the idea being that they go into a situation, they use their relaxation skills, and the anxiety habituates. In other words, in any situation that evokes anxiety, if you stay in it long enough and nothing bad happens, the brain essentially gets corrective information. This situation can't hurt them, and the anxiety goes down. So exposure therapy combines these 2 approaches to exposure: imaginal exposure and in vivo exposure to real situations. Of course, the challenge with exposure therapy is that people have to be willing to directly confront fear-based trauma-related memories and situations. But there's a lot of evidence that when they do, it's extremely effective. Another widely used technique or method in the general population, with some evidence in people with serious mental illness, is eye movement desensitization and reprocessing therapy, called EMDR. I'm not going to go into a lot of detail here, but EMDR includes components of exposure therapy and components of cognitive restructuring, with an additional distraction component. When a person calls the trauma a memory to mind, the clinician uses a kind of distraction. The traditional one was wagging one's hands in front of them, but it's also been used in terms of tapping and things like that. And the thinking is that this distraction technique reduces the anxiety and facilitates the treatment. This, by the way, is our book on the cognitive restructuring program that I think I mentioned earlier. It also has lots of information about assessment and background about post-traumatic stress disorder and its treatment in people with serious mental illness. I'm going to give you a little bit of, I'm going to show you one of the 2 randomized controlled trials that I did on the cognitive restructuring program, and then move on to talking about other treatments. This is the first study that we did. The second study was actually twice as big. And this was a study comparing the cognitive restructuring program with usual treatment. There were 108 people in the study. It was done at 4 sites in New Hampshire and Vermont. Mostly the treatment was provided by PhD clinicians, but There was one master's clinician, and in the second study, it was all master's clinicians. We had assessments at baseline, after treatment, and then 3 and 6 months later. We focused primarily on PTSD knowledge and symptoms, supported by NIMH. Primary outcome was PTSD severity, measured on the clinician-administered PTSD scale. That's the CAPS, as well as depression. I'm just going to show you two outcomes. So this is comparing CBT as the green with treatment as usual is the red. And these are the average PTSD severity. At 0 is the baseline, 1 is post-treatment, 2 is 3 months after post-treatment, and 3 is 6 months after post-treatment. And so you can see both of them went down somewhat, but the CBT group, the cognitive restructuring group, went down significantly more. And then if you look at depression, on the Beck Depression Inventory, you see a similar, even a slightly more dramatic effect of the cognitive restructuring program going down much more than the treatment as usual group. Let's continue talking about a couple of more individual treatments for PTSD in people with serious mental illness. There's a fairly recently developed program, you could almost say accidentally discovered, called the BREATHE program. And BREATHE stands for Brief Relaxation, Education, and Trauma Healing. And the reason I said this is almost accidental is that in our second controlled study of our cognitive restructuring program, instead of comparing the program to treatment as usual, we decided to compare it to the first 3 sessions of the program, which are all focused on just psychoeducation and teaching the breathing retraining session. And of course, we expected the cognitive restructuring program to beat the hell out of this brief BREATHE program. And much to our surprise, the BREATHE program did really quite well. Cognitive restructuring was more effective, but a lot of people benefited from BREATHE. A lot of people just needed BREATHE. They didn't need the full program. And so that is another intervention. The manuals is included in our book. And actually, let me show you. This is before I go to that last one. We did a kind of open trial of the BREATHE program at Threshold Incorporated in Chicago. 225 clients have participated in it so far. Most had multiple traumatic events. We assessed PTSD symptoms and depression at baseline, post-treatment, and 3 months later. And here you can see the reductions in, this is the PTSD checklist 4 and 5. They changed somewhat, and so you can see some people had one, some people had the other, but consistent reductions from screening. Well, it's pretty stable from screening to session 1, but then significant reductions to the end of treatment and at follow-up. And the same thing in terms of the Beck Depression Inventory. So that's a little bit of data on the brief intervention. Let me talk about one last intervention. And this one is focused on processing the psychotic episode. And this is included in the Navigate program for first episode psychosis. And that's a comprehensive program for first episode psychosis. And within that program, the individual psychotherapy intervention is called individual resiliency training. And in the individual resiliency training, there's different modules focusing on different topics. Like one is focusing on distressing symptoms. One is focusing on recovery and goal setting. One is focused on medication and so on. And of the different modules, one of them is focused on processing the psychotic episode. And the idea is, or was, to take a narrative approach, helping people learn how to tell their story about their psychotic episode and parts of it that were upsetting, whether it was the symptoms, the treatment experiences, the labeling, being in the hospital, things like that, and to take control over their own story by telling it both verbally as well as writing it down. So it involves helping the client talk and write about their experience. And this personal story then often leads to developing a personal recovery of a personal vision of recovery. And the approach is based on narrative and written approaches to the treatment of PTSD in the general population. The Navigate program, including this component of IRT, was evaluated as a part of the NIMH RAISE, that's Recovery After Initial Schizophrenia Episode initiative funded by NIMH, which included a total of 34 sites participating in a cluster randomized controlled trial comparing Navigate with usual services for people with the first episode of psychosis. And the research showed that participants in Navigate had much better outcomes across the board at 2 years compared to the usual services. And it turns out that these outcomes were maintained at 5 years, although we do not have trauma-specific outcomes from that study. So let me talk a little bit about how families can help and then turn it over to folks for questions. First of all, it's helpful to be aware of the signs and symptoms of PTSD. If you know that your relative has had a traumatic experience, trying to provide a safe space to talk about it without pressuring him or her to do so. Many individuals who had traumatic experiences have kind of dual feelings, opposing feelings. On the one hand, they don't want to talk about it because it's frightening. On the other hand, they do want to because people have a natural tendency or desire to process challenging experiences socially and with other people. So if enough space can be created for the person to talk about it gradually and over time, generally speaking, that can only be helpful. Whenever possible, look for opportunities to normalize PTSD symptoms and related reactions as common responses to traumatic experiences. Even though we know a lot about what PTSD is, interestingly, a lot of people with PTSD don't know the symptoms of PTSD for the practical reasons that they're not talking about their symptoms with other people. And so they don't know that having these memories pop into their heads, having this incredible startle response when somebody comes up from behind them, they don't know that these are common symptoms of a disorder that many, many other people have. And so just educating people that these symptoms are part of a syndrome or disorder called PTSD, and that it's well known that many other people have it, and that there are effective treatments for it, just knowing that can provide a lot of reassurance to individuals. I've had many people say, I thought I was going crazy, about these thoughts as well as, negative feelings that people may be having. If your relative is open to it, share educational material about PTSD with him or her, like a handout. In the book that I indicated before, we have a whole series, an extensive series of handouts with worksheets all about PTSD symptoms designed to help people understand what they are, but also to personalize them, to identify what their own symptoms were. So PTSD symptoms are common reactions to trauma. You're not alone. It's widely studied. There's hope. And there's many options for recovering from PTSD. I used to think many years ago there was really one best way of doing it. But now I believe there are many different ways of doing it. And whatever brings somebody to the table of deciding to deal with their traumatic experiences, somebody who has PTSD, is going to be for the better. A little bit more. If your relative is recovering from a recent onset of psychosis, encourage him or her to talk about any upsetting experiences related to symptoms or treatment. Allow for multiple conversations if needed to help the relative process the experience. We know from exposure therapies that sometimes traumatic experiences get all jumbled up. And then as the person talks about it again and again and again, things begin to get a little bit more organized in their minds. And it's at that point that they can begin to understand their experiences and incorporate them into their life experiences. Don't push your relative to talk if they don't want to talk about it, of course. And as I indicated before, understand there's many different pathways to recovery from PTSD. Psychoeducation and breathing retraining may be enough for some people. Peer support can be helpful. Yoga, and I'm talking about things in addition to like the psychotherapy, cognitive restructuring, and the like. Supportive family members and friends, self-help books, exercises, and the like. All those things can be helpful. And one last for family members, it's very important to be aware of your own traumatic experiences and possible PTSD symptoms that you might have in order to practice self-care. These could be from experiences that you've had at some point earlier in your life. They could also be in experiences related to a relative developing a serious mental illness or a particular incident. So being aware of these experiences yourself can help you take a step towards taking care of that and recovering from PTSD or a subsyndromal case of PTSD should you have one. So to wrap it all up, PTSD is common in people with serious mental illness, and it's associated with high levels of distress, more severe symptoms, and a worse course of illness. Despite the high prevalence of PTSD, it's often undetected and therefore it's not treated, resulting in needless suffering. There are efficient and valid methods for assessing and treating PTSD in people with serious mental illness, and families can play an important role in helping a relative cope with and recover from PTSD. Thanks very much, and let me open it up to, or give it back to Julie and take any questions that people might have.
Great. Thank you so much, Dr. Mueser. We have some questions that have already come in your presentation. And so one of the questions was, how long after trauma do symptoms of PTSD perhaps become apparent?
Great question. In the most common situations, the symptoms of PTSD become apparent immediately after the trauma. But we don't, in fact, it's considered completely normal to have the symptoms of PTSD within the first month of trauma. And then what happens is that for many people, those symptoms gradually go away. For other people, the symptoms get worse. And it's the people for whom the symptoms get worse, those are the people who develop or have PTSD. It does sometimes happen that PTSD has a delayed onset. And the most common situations where it has a delayed onset is when the traumatic event occurs in a situation or a setting where the person has little or no safety. And therefore, they're constantly on guard. And the traumatic events, although they're remembered and the like, don't lead to the full range of PTSD symptoms until the person becomes safer. And this can happen in situations of, for example, childhood physical or sexual abuse, combat soldiers, and the like. And so it certainly can happen that those symptoms surface at another area. In those situations, in almost all cases, the traumatic experiences are still remembered. It's not like the memories are recovered. They're remembered, but the full syndrome of PTSD can have a delayed onset in those cases.
Gotcha. Thank you so much. Another question from the audience was, would patients with a serious mental illness have PTSD from events that may not seem typically traumatic, like on one of those checklists, for instance, a fender bender car accident or a sprained ankle from an exercise or something along those lines?
This is a great question. First of all, we know that when it comes to the effects of a traumatic event, if we stick for a moment to the DSM-5 definition of a traumatic event, of course, not everybody exposed to a traumatic event develops PTSD. Most people don't. But we also know that people with a serious mental illness, when exposed to a traumatic event, are more vulnerable to developing PTSD. So let's say there's a natural disaster or an unexpected death of a loved one. The same kind of event is more likely to lead to PTSD in people with serious mental illness than people without. So there's a kind of a vulnerability. But then the second thing is that according to the DSM, if somebody has one of these minor traumatic events, the DSM, according to the DSM, would not call it a traumatic event and wouldn't allow a diagnosis of PTSD. But the truth of the matter is that we know very, very well that the psychological perception or the impact of a traumatic event is what determines the PTSD symptoms. And in fact, it doesn't really matter if the trauma itself meets the DSM definition of a traumatic event. If it leads to, if it's experienced as psychologically traumatic, it can lead to the exact same syndrome of PTSD symptoms. And that can include, for example, certain psychotic symptoms, or people can do, for example, in bipolar disorder, when somebody is having a manic episode, they may do terribly embarrassing thing. They could run, take off all their clothes, or run in traffic and things like that. And they're mortifying. They wouldn't necessarily be considered a traumatic event, but they can lead to the same PTSD symptoms.
Oh, sure. Yeah, that makes a lot of sense. So in terms of what to do about PTSD, one of the questions is, are there medications used for PTSD?
Yes, the medications with the best track record for PTSD are antidepressant medications. Sometimes antipsychotics have been used. It's interesting because PTSD is one of the few disorders where the psychological treatments are definitely more effective than the pharmacological treatments. But that is not to
Mhm.
say that the pharmacological treatments don't provide a benefit. They certainly do.
Sure. Okay, thank you. So this is something that you might have some good information on or might be in the process of figuring out. How do you know which treatment is best for someone? For the example, let's say if someone's had a history of, repeated sexual abuse during childhood and, is now an adult, perhaps experiencing the manifestation of PTSD.
Right. That's a great question, and it may be of interest for the person asking it to for me to explain. I had been telling you earlier, Julie, that we have recently proposed a study to PCORI, the Patient-Centered Outcomes Institute, to address exactly that question, to compare exposure therapy with cognitive restructuring and to see if they're equally effective in people with serious mental illness, as well as to see if some people benefit more from one intervention than another. The short answer to the question is that we don't know at this point.
Mm,
I do think that there are strong reasons to think that when it comes to the particular traumatic event, and unfortunately too common, but the traumatic event of childhood sexual abuse, there are a few reasons to think that a cognitive restructuring approach may be a little bit a preferred or more powerful. And the primary reason is that in many people with childhood sexual abuse, a dominant emotion that they experience is guilt or shame.
yeah. Right.
And that this guilt and shame can even be stronger than the anxiety. And the
Mm,
difficulty with guilt and shame, if it's the primary emotion, is that when you do exposure to it, it doesn't go away with just exposure. And that
okay.
anxiety goes away when you expose the person to it, because if the
Yes.
person is exposed and nothing bad happens, it contradicts their belief that it's a dangerous situation. But if you think about guilt or shame feelings, the belief related to that is that you're a bad person or you've done something bad. So simply exposing the person to that belief doesn't lead to any corrective information.
Mm,
Whereas in cognitive restructuring, of course, what you do is you take the thought and you examine it, very dispassionately and analytically, looking to see if there's good evidence supporting it or not. And often, typically, of course, there isn't. Often people say, "Well, I should have done this or that," but then when they look at it, they realize that they didn't know at the time, or they were trapped.
mhm.
They couldn't get out of it. So,
Yeah.
I was involved in one study of exposure therapy with adult women with a history of childhood sexual abuse. And the exposure was very effective, but we had a much higher dropout rate than was really acceptable. We had about a 45% dropout rate.
Mhm.
So um, we don't have a lot more data than that, but that's the only group where I might hypothesize that one person is going to benefit, somebody's going to benefit more from one treatment than another. Probably they are relatively equally effective for different kind of traumatic experiences and the like.
Yeah, that makes sense. So this is a little bit of a different question. How can a family member perhaps best support a loved one who might be very focused on or perseverating on a past traumatic experience or experiences without being open to or considering treatment?
That's a great question. The first question I would have would be, are we talking about traumatic experiences that the person did have that they're very focused on talking about, or if there's a question about whether they're talking about traumatic experiences that really didn't happen? And it's a little bit of a challenging
Mhm.
question, but
Let's go with the
I'll kind of
first
get
assumption of maybe trauma of involuntary hospitalization, for instance.
right. So I think if it's an event that really did happen, and the person doesn't want to get into treatment, I think providing being supportive and letting the person talk about it, letting them process it,
Mm.
um,
Mhm.
and potentially providing education about PTSD. If they can be helped to process that experience and to integrate it into their life, and this is a little bit what the telling your story, the processing the psychotic
Right.
episode is about, that
Hmm.
could be very helpful. I should mention that there sometimes people are very preoccupied or focused on a traumatic event, but they don't have PTSD. because
Sure.
remember, PTSD has to do with avoiding, traumatic, trauma-related stimuli, having a lot of anxiety when thinking about them, and so the most typical person with PTSD doesn't talk about it very much. In fact, the last thing they want to do is to talk about it.
Yeah.
And so it may well be helpful to talk to help your relative to talk about it, certainly to some extent.
Hmm.
But at some point, you may also want to kind of move on. And it is possible that the relative doesn't have a PTSD. And so
Hmm.
if they had PTSD, talking about it would certainly be helpful. If they don't, it may well be helpful as well, but maybe not as helpful, after a period of time.
Gotcha. Thank you so much. So let's see. One person asks, how can we help folks who may not meet full criteria for PTSD, but still have some subclinical symptoms as a result of trauma, that certainly have an impact on functioning their relationships? What treatments or components of treatment would be appropriate to offer?
Right. So I think that the same basic treatments, cognitive
Mm-hmm.
restructuring, helping a person really identify challenge and change, inaccurate thinking, often
Hmm.
trauma related, even though the symptoms may be, at a modest level,
Hmm.
that could certainly be helpful. At a very
Yeah.
basic level, psychoeducation about the different symptoms can
Hmm.
be helpful in terms of helping people recognize that they're not alone. And along with psychoeducation, there is a wide range of different coping strategies that people can learn to deal with common symptoms, whether it is a difficulty sleeping. We know there's a whole area in terms of sleep hygiene, whether
Sure.
it's learning how to deal with situations that remind the person of the traumatic event but are nevertheless safe.
Hmm.
Um, Even if it's nightmares or things like
Hmm.
intrusive memories, there are many different kind of coping strategies. But and the person might not, have the full syndrome of PTSD, but they can still benefit from that. But if they have enough of the symptoms, I think the basic psychoeducation and teaching some relaxation skills, like in the Breathe program, that's certainly the way to begin. They don't have to have all of the symptoms to benefit.
Gotcha. Sounds like this could be helpful for a lot of people, and it doesn't have to
Yeah,
just fit into a certain box to be helpful.
absolutely.
Okay. Um, and so, everyone's situation is different, and we can't necessarily give medical advice on this webinar. However, let's say if someone has at some point, in adolescence or, sometime in childhood, experienced traumatic events, and you know, later as an adult, someone is diagnosed with a thought disorder or perhaps schizophrenia,
Yep.
is it possible that there could be misdiagnosis? Maybe in fact someone does have PTSD and not schizophrenia. Um, I suppose people might have different thoughts about that, but any thoughts for
No,
yourself?
I'm glad that you asked that because it's a really interesting question. I only had so much time, so I didn't put it into my presentation. But so it is, you can have a person can have psychotic symptoms due to PTSD and not have another diagnosis like
Mm,
schizophrenia, a schizoaffective disorder. The first paper I published on PTSD was all the way back in 1987, and it was of work I was doing with Vietnam War veterans. And what we
mm,
noticed was that a significant number of them had auditory hallucinations, many of them trauma related, but not all.
okay.
None of them had schizophrenia, and none of these could be explained
Mm,
by a major mood disorder. And there is a literature showing that psychotic symptoms can and do happen in people with PTSD.
mhm,
And I have worked with a number of cases where there was a misdiagnosis. I even worked with one case a number of years ago where somebody was in the VA hospital with a diagnosis of schizophrenia, and a careful trauma and PTSD assessment was done. He was found to have PTSD. He was provided, actually, in this place, he was provided an exposure therapy treatment. His PTSD symptoms went away. They took him off medication and they discharged him. So
mm,
it
mhm,
can happen. It probably doesn't happen that much, but the thing to be aware of is when a person is presenting with psychotic symptoms, if to evaluate whether post-traumatic stress disorder may also be present. If post-traumatic stress disorder is present and very severe, then there's a possibility that the psychotic symptoms are related to it. Some of
sure.
the differential diagnosis might be, for example, negative symptoms. You're not
Mm-hmm.
going to get as many negative symptoms. You're going to get avoidance and withdrawal, but it's
Mm,
very active to avoid anxiety-provoking situations. You're not going to get this reduced drive that you get in the negative symptoms of schizophrenia.
mm-hmm.
The severity of the hallucinations is usually somewhat milder.
Mm-hmm.
Often, the hallucinations and the delusions are thematically related to the traumatic events that the person experienced. And of course, it's possible to have both the PTSD and the psychosis. But the shortest
Sure.
answer to the question is yes, this does happen
Sure.
sometimes. And kind of one of the questions is, does the person look like a typical person who has just developed a psychosis, or do they really look a little bit different in
Mm.
terms of anxiety and the like being primary in the presentation?
Thank you. So this next question is more from the perspective from someone who has experienced trauma. So how can one safely acknowledge or share to family, one's experience with trauma or PTSD without reliving it again or experience new PTSD from perhaps negative reactions from family members? Any advice on how people could share that information and feel safe doing so?
Yes, I guess the first question I would have is whether the person has been able to share it with somebody in their life, whether it's
Mm,
like a clinician, a friend.
right. Okay.
Um, if the person has been able to find somebody that they can share it with,
Hmm.
then what the person will have learned or will learn if they haven't done it. But what they'll find is that the sharing of these experiences is not re-traumatizing. That's what
Mm,
people are
hmm.
afraid of because
Yeah.
the thoughts are upsetting. And this is
Hmm.
what people learn in exposure therapy in particular, but they also learn it in cognitive restructuring, which is that the talking about it can't hurt you. Even the memories can't hurt you. They're
True.
different from the event. And so the first thing is to find the kind of supports that would enable the person to be able to talk about it with somebody. And if they really haven't talked about it, it may take a bunch of talking because the
Hmm.
more you talk about
Hmm.
it, the more the person's going to be able to kind of organize it, feel safe with it, and things like that. And
Hmm.
at the point when you are then able to, you feel more comfortable with talking about it with at least somebody, then sharing it with family members really is a useful thing. And this is
Right.
how we do it when we treat adolescents. When
Mm,
an
hmm.
adolescent develops PTSD, what we do is we usually use a combination of the cognitive restructuring. Sometimes we'll help people write and tell their stories, like written down, similar to the processing the psychotic episode, but it's a
Hmm.
traumatic event. And at the point when the adolescent really feels kind of in command of it and okay with it, and then if they're willing to, then they'll often share it with family members.
Yeah. Okay. Thank you so much. Unfortunately, we don't have time for any more questions at this point. We had a very lively discussion though, so I'm going to share my screen for closing remarks and we'll close out from there. Okay. So, um, thank you so much for everyone joining. We do have some resources at McLean. If you do have a loved one, especially who's experienced serious mental illness or a different psychosis experiences, we also have a resource sheet that I'm going to try to share in the chat for folks who might be interested in even more resources later. So let's see, I think that should be going through now. And because we really love having great speakers like Dr. Mueser come join us, please feel free to share your feedback on what you think went well in this webinar, other ideas for future webinars as well. And I will put this link in the chat and I'll give folks a second to log on to that if you like. It's just a few questions. And then I want to thank everyone who's really made all of this work possible over time, our generous philanthropy donors to our division who sponsor this, our research funders, and our collaborators. And our next family webinar will be next month, second Thursday, May 14th, 5 to 6 p.m. again, and it will be on mental health stigma overview and support resources. And this will be with Dr. Philip Llanos from John Jay College at the City University of New York. So I really hope you all have a chance to join us next time. If you sign up for one of the webinars in this series, you're welcome to sign up for all of them or join all of them. You don't have to sign up more than once. And then if you have any questions for me, again, I'm Julie McCarthy, and my contact information is here. And so thank you so much. And Dr. Mueser, again, thank you for all of your insights and for your decades of contribution to the field. I don't know what we would do without you.
Thank you so much.
All right, take care. Bye.